I would have never known I wanted to be a surgeon had I not actually put myself in this situation where I can get exposed to surgery and realize, wow, I really love it.
Welcome to Specialty Stories. My name is Dr. Ryan Gray, and I'm excited that you are joining me today for a great guest. We have Dr. Brian Lima, a cardiac surgeon who has an amazing story about his journey to cardiac surgery, his destiny to cardiac surgery. And we have a great discussion about cardiac surgery. What's it like, the competition or the actual technology changes and what that leads to for the future for cardiac surgery, and much more. This is a great follow-up episode to last week when we had an interventional radiologist on. You should go listen to that one if you haven't listened to that one yet. Go listen to that after this one if you want to see some comparison and contrast, because the guest last week potentially wanted to do cardiac surgery and then changed his mind after learning about interventional radiology and the future and technology of interventional radiology. But this week, Dr. Lima is going to talk about his love of cardiac surgery, the jet setting around the country, going and procuring organs and coming back and helping transplant them, especially, obviously, the heart, since he is a cardiac surgeon. I hope you enjoy this episode, and if you want to hear more about Dr. Lima's journey, go to brianlima.com. He has a book out, Heart to Beat, by Dr. Brian Lima. We start the conversation by finding out when Dr. Lima first became interested in cardiac surgery.
In college, I did a summer program at NYU. It was like a summer research program between my junior and senior year. And before then, I thought, doctor sounds cool. I had no idea. My older sister was an X-ray tech, so she always talked up radiology. She's like, I work with radiologists. They're so great. They have such a great lifestyle. So I kind of had that idea, but I had no idea. And I got to shadow surgeons at NYU, and I got to watch. It actually wasn't even a heart surgery; it was like a colon operation. But they let me scrub in, and I had never been in the OR before, nothing like that. And I scrubbed in, and I was like, "Whoa, this is the coolest
You
thing."
didn't pass out,
ever. Right? No.
Okay,
It's like binomial. It's like either you pass out and throw up or whatever, or you think it's the greatest thing.
Yep.
So I was in the latter group, and I was like, I want to do that.
Yeah.
And it evolved from there, because when I got to medical school, I got to see, the hierarchy of kind of residency and surgery, and the longest training was heart surgery. And these were it seemed to me at least, like the meanest, baddest, they knew everything. They trained for 10 years.
They were the rock stars.
I just looked up to them. I was like, wow, I want to be like that guy. So that's how it evolved.
Yeah. So it's interesting. I didn't plan this, but it kind of works out that the interview that went out the week before yours is with an interventional radiologist and someone who wanted to go the cardiac, the kind of CTS route, and kind of saw the direction that cardiac surgery was heading. And was like, I'm going to go more of the IR route because that's where tech is heading. Did you ever have that question in your mind to where these open surgeries are becoming less and less common because we have the technology to do it endovascularly? Is that a discussion that you ever had, or were you dead set on, I really have this goal of heart transplantation, and so obviously we're not going to do that minimally invasive anytime soon?
Right. So it was, I had heart surgeons saying, I don't know, man. I don't know if I had to do it over again, but if you look at the field, like you've said, heart failure is growing exponentially. So we're going to be dealing with this in all facets of medicine, regardless of what area you go into. And the need for some form of heart replacement therapy, whether that's heart transplant or the devices that are evolving to do that, artificial heart pumps, that all has no signs of, and that's very techy too, and it has no signs of slowing down. So since that was my area of focus, I felt like the future was, definitely going to be bright for that area. Now, certainly other parts of cardiac surgery are evolving too, but I think what we learned the hard way with, interventional, coronary work is that we're not going to be so readily, easily give it up to the cardiologist. So, the whole heart team thing with percutaneous valves. So that's a heart surgeon and a cardiologist working in tandem for all of those procedures. So I think we've learned our lesson, but there's still plenty if anything, I think there's going to be a critical shortage, which we can get into, of heart surgeons in the future.
As you went through the process of being a pre-med student, going to medical school, applying to residency, did you ever waver on your path to cardiac surgery, or were you dead set on that path the whole way?
I was dead set on it, but I mean, it was hard. It was such a long, 10 years of training is a long time. 10 years, 7 years of general surgery with 2 years of research stuffed in there. And I think what I started to see as I came through is that less and less people out there were, dare I say, crazy enough to delve into such a long period. And so that's what kind of spawned these I6 residencies. So now, instead of having to do the full general surgery and then, 2-3 year fellowship in cardiac, much like neurosurgery, ortho, ENT, you can match straight out of medical school into cardiac surgery. And which is how, England and, South America, that's how they've done it forever, right? So that's kind of how things have changed, because I think people started to realize, do I really need to do 200 gallbladder removals if I know, I'm going to be a heart surgeon? It made no sense, right? To that degree. So finally, I think common sense, won the day. But I had to go through the regular old school, way. It's not fun. Yeah.
What are some of the biggest myths or misconceptions around cardiac surgery?
Well, it's funny because most people say, "Oh, wow, you're like really nice for a heart surgeon."
Yeah.
Like you imagine like Alec Baldwin and Malice, like just totally, God complex and like screaming at everybody and full of themselves. But I would argue that heart surgery is the most humbling field, in my opinion, because at all, whatever, let's call it 100 steps of any heart surgery, you can kill somebody, right? And so a mistake means somebody dies. I mean, other kinds of surgery, those types of mistakes the stakes aren't as high, I would say. So because when I came through, I kind of had those misconceptions too, right? And but as I've gone through it, I'm like, wow, this is humbling. Just when you think you got it and you're like, oh yeah, I'm it, and then wham, something happens. So it's very humbling. So that's a huge misconception, the whole God complex. And really across the board, all areas of medicine, the stuff that used to fly, 15 years ago, 20 years ago, being mean and just sort of, that doesn't work. I mean, people won't put up with that anymore. Everyone has been empowered, from the lower tier all the way to the lowest rung, top rung of the team. Everyone has a voice. Everyone's empowered. So you can't sort of have those shenanigans won't fly anymore. It's just not. This is not going to happen.
Yeah, definitely going through my training, third and fourth year was that 2008, 2009-ish time period. There's definitely some surgeons that are still screaming at people at that point. I'm like, wow, like, okay, that's how we're going to play this game today. Oh, all right. Luckily, it usually wasn't directed at me, but yeah.
Yeah, not touchy-feely, but it's getting better. It's getting better.
Good.
Yeah.
Let's talk about the types of pathologies, the types of patients that you're seeing and treating. As a cardiac surgeon, I think one of the biggest misconceptions that's probably out there from the students is all you do is heart transplants. Like you just take a heart out and put one in, take a heart out and put one in. What other sorts of things are you doing with patients?
So it runs the gamut. So, you can take coronaries, right? So coronary artery blockages. Many of those patients require bypass surgery. As much as the stent technology has evolved, it still can't, there's still scenarios where, 3-vessel disease, low ejection fraction, things like that, coronary artery bypass is still the gold standard. So there's a lot of that. There's all the structural heart stuff, so all the valves, so aortic valve, mitral valve, tricuspid valve, any stenosis or regurgitation, endocarditis, all of those require surgical intervention. If you can do it with the transcatheter approach, great, but often it's not, it's not doable with a transcatheter. Less and less so these days, but a lot of that is still open surgery. All the aortic pathology, aortic aneurysms, aortic dissections, often require open surgery. So there's still a great deal of stuff that's within our sort of wheelhouse of things that we do that run the gamut. So
Yeah, lots of different things. How many
yeah.
of the patients that you see in a clinic setting, making the assumption that you're seeing patients in clinic and not just operating all day long, but how many of those patients are you actually taking to the OR versus sending for other types of therapy?
So my view of that is a bit skewed in that I often, since my main niche is in heart failure, so I'm seeing patients often that are already hospitalized for decompensated heart failure. So they're already hospitalized, and our team is involved in determining if they're a candidate for advanced therapies, a heart transplant, a left ventricular assist device. So I would say of all the patients that we are evaluating, whether it's outpatient or inpatient for advanced therapies, I would say probably maybe a quarter of them or half of them end up meeting the criteria or going on towards needing a transplant or a VAD or getting one. I would say there is a big screening process that happens as the patients eventually make their way to us. We're sort of the end of the line, so to speak. So by and large, I would say if a patient gets sent to us to be seen, in our office, or we get called about a patient who just gets cathed, right? That happens a lot. You get a call from the cath lab, hey, just cath this guy. He's got 3 vessel disease. Can you bypass him this admission or whatever. So there's a lot of screening that already goes into it. So a good chunk of the patients that we are called about are surgical, candidates for something.
Yeah. I want to divert a little bit from normal specialty stories discussion. With your role in transplantation, in this country, we have an opt-in system. Usually at the DMV, when you go get your license, you're asked if you want to be an organ donor. In a lot of countries, it's an opt-out system where it assumes you're an organ donor and they ask if you don't want to be one, and human psychology tells us we kind of stick with the default. Do you think we should switch to an opt-out system here in this country?
I believe we should.
Yeah.
It's obviously a touchy subject, but I think there's such a huge disparity across the board of some states that have really really good rates of people signing up and they just do it, and other states like New York, where I happen to be, is the worst state
Really?
for that.
Wow.
Yeah, and so that really does hamper our ability to get donors. And of course, people have this misconception out there that oh, I don't know, I signed up to be a donor, they may not, push comes to shove, they may not try as hard, which is like the craziest thing, right?
Yeah.
Because if anything, you could say we're more guilty of kind of really sticking it out when things are obviously like we're very reticent to throw in the towel. If anything, we're like, no, let's keep pushing, whatever. So I can't even remember, we looked at his license. This guy's
He's an
not a
organ
donor,
donor.
so maybe I was like, doesn't even, it's like the furthest thing from, so it's crazy that people still think that.
Yeah.
But
Thanks,
it's
Facebook.
a shame. It's a shame. Seriously.
Oh, yeah. I've seen those memes on Facebook. That's where it's all from. What does a typical day look like for you?
So I get up super early. I'm a big believer of, conquer the morning, kind of just set the tone. So I should say I get called frequently at night, throughout the night, for donor offers, for heart organ offers. And without fail, they tend to happen between 1 and 3. So I have the sleeping habits of like I guess a newborn, where I go to bed early, and then because I know I'm going to get, nailed in the middle of the night with the calls. So then I go back to sleep. So I get up around 4. So I'm usually at the hospital by before 6 or 6-ish. OR is at 7:30. So, see all my patients in the unit and on the floor. We do our formal rounds, and then get to the OR. Do a case. Because of transplant, sometimes it's unpredictable. So sometimes, I'll have a free day or two, and then other times I'm just operating for days on end. Just sort of that feast or famine type of phenomena that happens. So on any given day, I have a case, and then in between cases or after I see my patients again, I have probably the sickest patients in the whole hospital. They're on a bunch of machines, different pumps, supporting the right side, supporting the left side. So they require a lot of micromanagement. So I usually see those folks throughout the day, a few times a day, and obviously make sure before if nothing's happening, which is rare, 5 or 6 o'clock, I can probably, safely get out of here. But often there's something else that's going on, and I stick it out to see, how I can help.
How does that affect life outside of the hospital, family life, et cetera?
Because of the sort of how the swings are, and it's unpredictable. So, when you're on call for the week or whatever for transplant, that you're just a sitting duck in a sense, that anything goes, anything happens. So, and really it also depends on the kind of family life you've set up. So if you have, I lucked out. My wife is really understanding. She gets it, right. I mean, sometimes it's really beyond my control.
Yeah.
But what you try to do is, you gotta make up. If you had a bad week or a bad day, then maybe you make the next week or the next day better. You try to sort of, have it all even keel when you can. So I do it day by day, and I would say it's doable. It's manageable. It's not as hard as what residency was.
Yeah.
Because at the end of the day, you can still, you have other partners you can work with to set up a call schedule. You could set it up in such a way that you have a life. It's just going to ebb and flow.
Yeah. I think a lot of students, when they hear heart transplantation or transplantation in general, they picture jet setting around the country, doing procurements and getting that call and heading to the private airport on the private jet. Does that still exist? Who's going out and doing the jet setting?
Well, either I am or I have other partners. So because the recipients often are pretty complicated, so that's a whole other surgery in and of itself to, for example, explant a artificial heart pump or an LVAD. That's 2 hours of work right there, because the timing has to be down to the minute, because heart really, you want to try to keep it the ischemic time under 4 hours. So usually you divide up with your partner. So let's say your partner's going to get the heart, right? And then you are working on the recipient. If it's a second or third time in the chest, you have it such that when that donor comes into the OR, you're already dissected out. You're ready to, take the heart out. Because if you don't, then the heart's going to sit there in the ice, bucket for another 2 hours. So that has to be really tightly orchestrated. But I did a lot of since I'm the director of the program, and some of these patients are pretty complicated, by and large, I'm mostly on the recipient end of it. But I've done countless donor runs. They're fun.
Yeah.
The problem is they're never at 9 a.m. They're at 1 in the morning.
Yeah.
That's the trouble with that.
Yeah.
So
you get to sleep on the private jet. Yeah, I've done one, and unfortunately it was just right down the road at a different hospital. We got to take a car. Not a fancy jet.
Helicopter's fun. We can sometimes do the helicopter.
I don't trust helicopters.
No. Yeah.
No.
That you got to have the stomach for it, but they're fun. I think they're fun.
Yeah.
It's exciting.
I have my private pilot, but for fixed wing, I don't trust helicopters. Yeah. That's funny. So talk about the training path. You talked a little bit about how there has been a big change in the training. What does that look like now for students?
So I think students have actually 3 options. There's the regular, traditional, if you want to call it that way, that I did it, where you do general surgery residency first. And general surgery residency, clinically speaking, is 5 years. Many programs, though, upper tier programs typically will sort of want you to do 2 years of research within that too. So then, and it becomes 7 years. So I trained at Duke, and Duke is everybody does the 2 years of research, and it's typically years 3 and 4. And actually, you kind of get to moonlight during that time. Still engage, in the ICU work or go on heart, procurement. So I did a lot of that, and it was great. And then, your fellowship for cardiothoracic can be anywhere from 2 to 3 years. It depends if you're going to a cardiac track or a thoracic track. And I think if there's anything that's changed in our specialty is the days of doing a heart transplant and taking out a lobe of a lung and then doing a carotid, all as part of your routine practice, that's probably not realistic. You kind of have to declare a major.
Yeah.
You're either a heart surgeon, you're doing straight cardiac, or you're doing straight thoracic, lung or esophageal work, or you're vascular, which you're not even going to CT surgery for that. So, so that's where the track, concept comes in for the fellowship.
Yeah.
So that's a traditional way. Then there's the other extreme, which is I6, an integrated 6-year, where straight out of medical school, you match into an I6 program where you do a little bit of general surgery, a little bit of vascular, cardiac, thoracic, and it's all within 6 years. Granted, the difference there is you can't sit for your general surgery boards. Not that you would need to or want to per se, like I said before, no need to do 100 colon resections and
just
100
itching to do a gallbladder.
yeah, right. So unless you're really, so that's where you kind of take yourself out of contention for that.
Yeah.
And then there's some programs that do like a hybrid where, maybe not I6, but you do maybe 4 years of general surgery and you go into 2 of,
yeah.
But I think increasingly the I6, and they become pretty competitive.
Yeah. Well, let me ask you, a lot of the surgical subspecialties, when I have these conversations, a lot of times that general training comes in handy because as you graduate your residency/fellowship training, coming out and practicing, you have to build up your specialty patient load. And so having that general training is what keeps you busy until you start building up that. Is that not a problem for cardiac surgery?
I would say that there's 2 things I would say. One, it's not everybody that knows out of the gates that they want to be a heart surgeon. And so having the general surgery backbone, it's such great training and it really covers the spectrum. It really does also put you, exposes you to different, all kinds of, subspecialty areas. I mean, colorectal, plastics, abdominal transplant, CT surgery, and the whole 9, right? So if for someone who's not 100% sure they want to do cardiac surgery, I think it makes sense to do general surgery because you may change your mind and you're a full-fledged general surgeon, and that can you can do all sorts of things with that.
Yeah.
So that's one thing. The other thing is the paradigm shift. So I think not that the jury is still out, but you have to be sure if you're doing an I6 program that you're going to a place that's going to have the patience to teach you these things. Because back to our original discussion about the ogre, heart surgeon, before they were used to having a fully trained general surgeon, to yell at, right, to, teach them heart surgery. But now if you're coming in, you don't even know how to suture, you don't even know how to tie, you're like learning that. Can you imagine? Like, yeah. It's just like, that's going to be a tough one too. So you got to make sure, obviously, that these programs have a good track record for their I6 trainees.
Yeah. I'll never forget when I was doing my internship, there was a Tufts medical student where I was at, and like, I told her, I'm like, you need to go start an IV on this patient. She goes, no, I don't want to. I'm like, what do you mean you don't want to? Don't you want to learn? Yeah, no, I don't want to learn. That's what the nurses are for. I'm like, oh, come on.
Unbelievable.
Yeah, I jump at those chances. Oh, well.
Different world.
Yeah, but we work with it. So for the student who is interested in one of those I6 programs, they're dead set on being a cardiac surgeon. What do they need to do to make themselves competitive to match into one of those programs?
So I would say 2 things are critical. One, obviously, to get a lot of exposure, deep exposure in those areas. So do a sub-internships in cardiac surgery, electives in cardiac surgery. You obviously want to have cardiac surgeons that you worked with that can sort of speak on your behalf and get you a good letter of recommendation, endorsement letter. That's key. And if possible, getting involved in some research early on in med school. Year 1, maybe identifying a cardiac surgery mentor, help with some, chart-based, clinical outcomes projects, things to sort of wet the whistle, get involved, start to learn the lingo a little bit, the field, kind of and who knows, get some abstracts out there to present at national meetings, or have their name on one of those, or research that, because I6 programs are competitive. I would say so. Anything that you could do to set yourself apart and to sort of reinforce that that's really what you want to go into, I think, is key.
For the osteopathic medical student listening to this, what do they need to do to overcome any sort of negative bias that may be out there at some programs?
Sure, and I think those two things still apply. I mean, I think you still need to be really proactive about getting your feet wet and exposure in experience in that environment in cardiac surgery, getting to work with cardiac surgeons so that they can see your work ethic, see your clinical sort of performance and all that, and speak to it. And then the research. I think unfortunately we hate to say this, but they probably need to do pretty well, right? Grade wise, and on their step 1, step 2, all those things. Maybe even, I did a whole year of research during my medical school education. Granted, it was built into the curriculum, but that's actually few and far between. Many places, many medical schools, you have to take another year. So even considering doing that, a year of research during medical school in cardiac surgery related area. So that's probably where I would start.
Yeah. For the future primary care doc listening to this, is there anything that they need to know about heart failure patients, future cardiac transplant patients that will help you do your job better?
I think the biggest thing is that heart failure, we know, is more deadly than most cancers, yet it doesn't garner the same street cred that cancer does. So if a primary care doctor is seeing a patient and feels a breast lump or an x-ray with a shadow worried about a lung tumor, it's like automatic, knee-jerk reflex. They're going to see an oncologist, right? I mean, there's no questions asked. That's it. Heart failure, though, is kind of like, well,
here's some Lasix.
Vitals are, here's some Lasix, some ACE inhibitors, let's see what's going, you seem okay. Let's see how this goes for a while, right? And then, then we get the patients too late.
Yeah.
Or they get to us in the 11th hour and the wheels have fallen off and they're like, transplant? What are you talking? We have to do this whole crazy long evaluation. And we're like, well, wait a minute, you've never had a screening colonoscopy, you've never seen a dentist. Now we're trying to do all this stuff, like at the 11th hour. And it just, I think if these patients were sent to us earlier, before the wheels fall off, so that they know, hey, this is an eventuality, possibly, let me get all my ducks in a row, things like that. And having, from a primary care perspective, a very, very low threshold for referring them to a heart failure specialist, just to be sure that it's not too early, or, to educate the patient. Who knows? It may encourage more compliance with medications. Like, oh boy, I better get with the program because I don't want to end up having to get a transplant or something like that. So
that's where I'm a huge tech fan, and technology, I think, can fix a ton of things. And when you said that, I'm like, well, if we had a centralized EMR, right, we can build in those sort of algorithms. As soon as that heart failure diagnosis code comes across, here are the 10 next steps that need to happen. And we're not dependent on the primary care doc relying on his or her own knowledge to do those things. So,
and that's going to be a huge problem going forward, because it's going to be more and more patients with that unfortunate disease. So.
Yeah, and even post-COVID, right? What's COVID doing to hearts? We know it's causing issues. What are we going to have a huge kind of onslaught of heart failure patients in the future?
We may very well. I mean, the jury's still out, but we're seeing some funny stuff, right? With the heart, these delayed manifestations, these lingering heart issues, hypercoagulable states, all these things. So, we really need to get on the ball there and be sure we're not, missing something.
Yeah. You talked about kind of picking out your niche with heart failure. What other sort of subspecialties within cardiac surgery are there for people who may be interested in it?
So there's the minimally invasive valve space, structural heart space, where you can not only work with cardiologists on catheter-based valve replacement therapies, but also if it calls for an open surgical intervention, that you can do it in a minimally invasive way, small incisions, robotic, that sort of thing. So that's one. Another kind of niche area is aortic stuff, where you're well versed in open approaches to fixing or replacing any segment of the thoracic aorta from the root all the way down to the descending, and also with catheter-based, stent-based ways of doing those things. Those two. And then, regular heart failure, we talked about LVAD transplant. That space is still going to grow exponentially. But I would say those are the three, phenotypes in cardiac surgery. There's still going to always be a need for coronary surgeons as part of that practice. There's always a need, for open surgery for endocarditis. But if you were to say what are the three big niches, I would say those were the three.
If you could go back and tell your early self something that you know now, kind of warn yourself or motivate yourself, what do you think it would be?
It would be to learn more about business stuff, meaning how a hospital functions, how, all this stuff, RVUs and capital investments, and how just the flow of hospital, the business of hospital administration, all those things. I didn't know any of it at all, zero. I just had this assumption that you walk into your first job, and all right, where are my patients? Let's get cracking. None of that. How do you work on referrals? How do you interface with people in the community? All those things. It's a business, really. How do you're a new commodity on the market. How do you build your brand and get people to refer patients to you?
Yeah.
It's not autopilot.
It's not
naively thought.
It's not a field of dreams. If you build it, they will come.
Exactly.
Yeah.
So I would have definitely boned up a little bit more on that stuff during med school and beyond.
What do you like the most about being a cardiac surgeon?
I love it. I lose track of time. I mean, it never gets old. When I'm in the zone doing a surgery, it could be 7 hours. I don't even feel it. It's just, when you love what you do and you're passionate about it, it's just, and it's so, the impact is just massive on these folks. They're one, minute they're totally incapacitated by their heart disease completely. And all of a sudden they have a new heart and they can breathe. You can just tell, and they just feel such an immense relief. That's so rewarding. It really is.
Have you had any of those moments we see on social media nowadays of family members going to a patient who has their loved one's heart now inside of them and listening to their loved one's heart? I've never cried at any of those, I swear.
Yeah, I've had patients who finally, because we sort of, obviously, it's like HIPAA, right? But eventually we do allow for those types of exchanges to occur. And I've had, it's such a surreal, amazing, moment for these people. And to see that, and it's the emotion, you can't even, describe those emotions. It's intense.
That's awesome. Yeah. What do you like the least?
Well, I think that it's the unpredictable nature of it, and the fact that because of what my niche is, I often see people that get to us too late, and where it's like you have therapies, you have things that you could offer, but sometimes people are, the window of opportunity sometimes can close on you before you want it to. And no matter what you do, it's sort of the die have been cast, so to speak. So that's really disheartening because, if you had seen somebody sooner, I think for me, it speaks to the flaws in the paradigm of how we, of healthcare, of how we, manage patients. To your point, the central, EHR, just not having things protocolized and such a wide, spread in how patients are managed and when they're referred for heart failure. I think it's really frustrating. I think there should be, I write about this and other, we should treat it more like cancer. Protocolized, automatic, tumor board. This is what happened. You have this. Okay, this is what you get. This is the chemo. It's just all out there.
Yeah.
So that's, to me, the most disappointing part.
We need a stronger lobbying body for you guys, like the
Absolutely.
oncology world has.
You're right. You're absolutely right.
What major changes do you see coming that may shift the future of cardiac surgery? I know I've seen some videos on social media of like turning leaves into these cardiac cells and other things. Are
Sure.
we close to growing organs, to getting rid of, whether that's stem cell treatments, getting rid of needing heart transplants? What's the future look like, do you think?
I think there's three competing sort of, it's like the Manhattan Project, three competing sort of modalities that are going to potentially do away with the need for transplant. One is creating the perfect mechanical substitute.
Yep.
So the holy grail right now is a totally implantable wireless pump, because all the pumps that we have, as great as they are, they're still battery. You still need battery, still a cord coming out that you're tethered somewhat to. So that is going to be a huge boom for the field, because when you eliminate that cord,
Yeah.
all of a sudden it becomes just synonymous, same thing as a transplant.
We just need
basically.
wireless charging.
That's
like our phones. You lay down in bed and you're
right,
charging.
100%. Or
Yeah.
like nuclear based power.
Yeah.
Who knows? Iron Man type of
Yeah.
thing. Who knows? So that's one.
Yep.
Number two is xenotransplant, figuring out how to crack the immunology code of
Yep.
getting other species organs to take in humans. That's still a lot of active work going on, and actually some pretty good success occurring there. And then third is the stem cell, the ghost heart, right? You have a heart, you digest away all the tissue on a scaffold,
Mhm.
and then you repopulate the scaffold with autologous stem cells. That, I think, is in development, and there's been some areas, some progress. I think that's a little further off. The heart is a pump, so I think the one that's probably going to win the race, if I had to bet, is the mechanical substitute. Just because of it's just figuring out that engineering battery issue, and once that's done,
have they solved? I know one of the early issues was that most of those pumps were just continuous pumps, and the body doesn't like that. Have they solved that issue where it's similar to the heartbeat?
Yeah, so the newest pump, the HeartMate 3, which has had the best sort of blood compatibility profile of any of its predecessor pumps, lowest stroke risk, lowest pump thrombosis rates. It's a continuous flow pump. However, they've embedded a pulse feature where the pump will ramp up and ramp down as far as speeds every half a second. So it's like an artificial pulse, so to speak. Yeah. That, I think, but more so, I think the design of the pump, spaces, less moving parts, the blood's just not beat up as much as it passes through, has really made a tremendous difference. So, I think more of that. I think really the key now is just the battery thing, is the power. That's the key.
Well, hopefully Elon is looking into that with all of his battery tech.
Got the answers. That's it.
Just walk around with a solar array on your head.
That's it.
It sounds like if you had to do it all over again, you would still be a cardiac surgeon?
100%. No regrets. Yeah. And what I tell students all the time is, if I have to talk you into doing heart surgery, if you have to talk yourself into it, you shouldn't do it.
Yeah.
It's got to be like all in.
Yep.
Yeah, for sure.
Any last words of wisdom besides, unless you're all in, be all out, for the student potentially looking into cardiac surgery?
I think before, I think the key, I would have never known I wanted to be a surgeon had I not actually put myself in this situation where I can get exposed to surgery and realize, wow, I really love it. I had nothing would have led me to believe that I would have, right? Until I actually put myself in that situation. So I would say, before making any, judgment about it, put yourself in the situation and see. And if you feel like, wow, this is amazing, then who knows? Maybe it's something for you to think about too. So I would say I would encourage people to actually get exposure before they really make their decisions about what they want to do with their careers in medicine. And the second thing I would say is, it could seem daunting. It is daunting in many respects, but anybody could do it if you are willing to put in the time and the effort. It's just one step after another leads to the next, leads to the next. So don't get discouraged. There will be dark days, but there's always a light at the end of the tunnel. Just kind of power through.